Hello, friends. Good evening once again to the NEET SS 2025 recall. And we'll continue with some of the questions that many of you were kind enough to send to all the faculty here. So we started off with breast oncology, and now I have another 4 or 5 questions in breast, after which I'll be dealing with thyroid and a bit of thoracic oncology today. Whatever else is left behind will be done as one single session later on because there are a lot of questions across the board in in gastro, in uro, in musculoskeletal, in so many areas there were questions. So today we'll be completing breast, thyroid, and thoracic oncology in this. So let's get on to the discussion now. So the last question that we discussed yesterday was on the classification of luminal B, what is going to be the HER2 type and the ERPR types that are going to be associated, where we saw there are two varieties. One is the luminal B, ERPR positive and HER2 negative type, where it is a high grade tumor. And then you have the HER2 positive, basically the triple positive kind of subset, or both HR and HER2 positive kind of subset, which may be of any grade. So these are the two subvarieties of luminal B that can be there. And based on that, the receptor status can also be different. Now, going on to the next question in breast oncology, what is the breast cancer subtype that is associated with the best pathological complete response rate? Now, when we talk about PCR, PCR is what is the short form for pathological complete response rate. Now, what is the definition of PCR? PCR stands for pathological complete response, which means there is no tumor identifiable post neoadjuvant systemic therapy in either the primary or in the nodes. So this is the definition of pathological complete response. Now, when you have a pathological complete response like this, which type is it more likely to be? It has to be a high grade type. That is the one which will respond more to your systemic therapy. So a high grade type of tumor is the one that is likely to have. So that straight away rules out most of the luminal A and the luminal B, leaving the HER2 enriched and the triple negative types. Now, classically, for most of the sort of like sources that I could gather from, and traditionally also the answer is going to be your triple negative breast cancer. Now, the best responses are seen in triple negative and in the HER2 enriched type. It is mentioned in Sebastian as well. The role of NACT even in early breast cancer is there in both these types. Traditionally, we know that neoadjuvant chemotherapy is used in breast cancer only in patients who have a locally advanced breast cancer. It may be T3, T4 lesions, it may be N2 disease or N plus disease. These are the scenarios where we will consider using neoadjuvant chemotherapy. Nowadays, the scenario is changing, and whenever, even before doing the surgery, we need to know the marker status. So if the markers ERPR and HER2 are all negative, meaning if it is triple negative, nowadays, even for a small tumor, even 1 to 2 centimeter T1 tumors, we consider going in for neoadjuvant systemic therapy, neoadjuvant chemotherapy. Now, why do we do this? Because the in vivo response is used as a marker to assess the response. We all know that whenever there is a PCR achieved, pathological complete response achieved, then the patients have a long-term cure, which is possible as compared to, the difference is something like when a same triple negative, same stage, everything is treated, T2, let's say, or a stage 2 breast cancer, triple negative is treated. Patients who achieve pathological complete response have a 5-year survival rate of around 75%, whereas it is around 60% in patients who are not achieving a pathological complete response, in the sense that there is any residue which is detected. So that is the reason why we need to know for prognostication. The second thing is additional adjuvant therapy is given. Now, this is based on something called as a CREATEX trial. Now, in the CREATEX trial, what happens is in patients who achieve PCR in triple negative breast cancer, no further adjuvant therapy is needed. So what is the traditional therapy which are given? It's AC followed by taxanes, or it may be some similar thing like FEC. FEC is usually not given, it's EC followed by T in many of these scenarios. So after the completion of chemotherapy, at the end of the time when you do the surgery, if the primary and the nodes have all regressed, then no further therapy is needed. On the other hand, any pathological positivity, any node which is seen, in such cases, then we have to plan for adjuvant capacitabine for 6 to 8 cycles. It is given as 14-day cycles as tablet capacitabine. It is a tablet therapy. It will be given for 14 days, every once in 21 days. So 2 weeks on, 1 week off, and the same thing will be continued. 6 to 8 cycles will be given. This was how the CREATEX trial was done, and that is one of the landmark trials that has come up in recent times on the role of therapy that we need to use. Similarly, in HER2 also, addition of pertuzumab is done in patients who do not achieve a pathological complete response. And all these are used as markers. And the traditional PCR rates are somewhere in the range of around 15% to 20%. Addition of other therapies, especially in HER2-directed therapy, if you add Herceptin, trastuzumab with pertuzumab, then you get a better PCR. It improves by around 5 to 10% overall. That becomes almost like, double or 1.5 times it becomes more. So that is the reason why we need to know about this pathological complete response. In today's world, it is considered to be one of the surrogate markers in breast cancer for achieving a long-term cure. So even if the patient has a negative connotation in terms of a triple negative disease, these patients may go on to have a longer survivor. That is the importance of the PCR, and that is best achieved in triple negative and closely followed by HER2 positive tumors. Now, this I believe was one of the questions which was a picture-based question or an image-based question which was given. So this is a direct question from Bailey. Someone had mentioned that it was a Bailey-based image of a tram flap. So you can see here that the patient has got a scar here, and there is the reconstructed breast which can be clearly seen. It is a kind of near complete or probably a subcutaneous, not really a subcutaneous. The mastectomy is completely done here. You can just see a bit of the breast envelope here in the top. The rest of it is having the tissue which is taken from the abdomen, and you can see here that the abdominal scar is there. Both of this together more likely makes it a tram flap, or it might be a DIEP flap. One of these two is going to be the option here. So in such scenario, what is going to be the blood supply? What is it based on? Now remember, friends, questions come from areas, as I stress again and again. Now, this kind of question is very, very common because breast reconstruction, question on flaps, question on the blood supply of the flaps, all this has come one time or the other, and tram seems to be a favorite with the examiners, or the abdominal flap seem to be a favorite with the examiners. LD may come the next time. So it is every time it is going to be slightly different. It's not the same question that will be asked. Some variation of the questions can be asked. Now, all of us know that this is clearly based on the deep inferior epigastric artery. So that is going to be the blood supply for both the DF flap. Now, in the DIEP flap, what is different? In the DIEP flap, it is based on the perforators of the deep inferior epigastric artery, whereas in your tram flap, it will be based on the deep inferior epigastric artery by itself. So tram is a musculocutaneous flap. It's a composite flap. You have muscle, you have fascia, and then you have the skin. All are taken together in your tram flap. Now, tram flap can be both a pedicle flap. It can be used as a pedicle flap where the flap will be taken from here. Usually, it will be the contralateral. Suppose you have the left breast to be reconstructed, it will be the right tram flap which will be taken, tunneled across here, and then kept here in the breast. It will be just folded and taken. And remember, my friends, the zones are going to be different. I have not drawn a picture here, but I have taken it in my classes as well, clearly mentioning that the zones 1, 2, 3, 4 are going to be different for flaps which are pedicle and for the free flaps. For both of them, the zones are going to be different. So kindly look at it. The Sebastian 21st edition gives you the correct zones very, very clearly. So just make sure you look at it. Don't be confused. It's like, it's not a printing error or something. One is for the pedicle flap. The other one is for the, what I can say as the free flap or the microvascular repair flap. So both of these, it is different. And the variations of the tram flap are, of course, going to be the MS tram flap, the muscle sparing tram flap, where a part of the muscle will be spared because in the tram flap, you're taking out the entire muscle along with the fascia, rectus sheath, and the overlying skin and everything. So there is going to be definitely a risk of herniation which has happened. Many cases may require a mesh reconstruction here. Bulging may happen. So these are all some of the problems that are associated with your tram flap. On the other hand, when you take a muscle sparing tram flap, you just take out with a small bit of muscle, leaving most of the muscle there. So it has got less mulch and less of these problems. And again, there is something called as a superficial inferior epigastric artery flap, SIEA flap or SIEB flaps, a superficial inferior epigastric artery and vein. That came as a question in the last NEET exam. So that is the flap which has got the least muscle morbidity. So which one has the least muscle morbidity? Is probably the superficial inferior epigastric artery and the vein flaps, because you do not disturb the deep system at all. The deep system is the one which is most important for the blood supply of the rectus muscle and the rectus sheath as well. In the SIEA flap, you do not disturb it at all, and that is the reason the least impact will be on the musculature will be in terms of the SIEA flap. We all know the next best will be the DF flap, where again most of the muscle is spared. It's only the perforators which are taken. So superficial inferior epigastric has got the least impact on muscle. The second least impact on the muscle will be from the DIEP, which is the perforator based free flap, which will be done. And cosmetically and generally speaking, for microvascular, which is the most common flap which will be used, that is going to be again the DIEP, the deep inferior epigastric artery perforator flap, which will be used. And now there are again some questions in terms of reconstruction which come again and again for the placement of the implants. Now, is it going to be submuscular? Is it going to be, basically there are two places where you can put it. One is going to be just under the skin, what we call as the subglandular implant, because it's skin and subcutaneous tissue, and the rest of the bit of the breast, whatever is remaining. So that is what you're going to use directly on anterior to the pectoralis major. If you put it, that is known as a subglandular implant or a prepectoral implant. The other one is going to be the subpectoral implant. Now, traditionally, it started off initially as prepectoral breast implants because it is very simple. You have the cavity, you put the implant, you close it, and you come. That is how it started off. But initial days, the skin flaps were very thin, and radiation was not as efficient as it is today, in the sense that it had more of complications. So there were a lot of loss of the skin. There was a lot of flap necrosis. There were a lot of implant exposure, infections. All this happened initially. So from prepectoral, it went back to subpectoral. So they had to dissect beneath the pectoralis muscle and create a pocket, and inside that the implant used to be placed, and that is how it started off. And because it will be covered, only the lower inferior portion, the infrolateral portion will not be covered. There they have to place an acellular dermal matrix so that it doesn't come directly in contact with the skin, and that is how it needs to be done. Nowadays, of course, because of better cosmesis and better techniques, better electrosurgical equipment, and also because now we know that we can actually put it. Now this pendulum is swinging again. So currently, the more favorable method is towards a prepectoral breast reconstruction. Still, the infection rates are higher with prepectoral, but that said, the overall risk of complications, reconstruction failure, hematoma, capsular contractures, reduction in size, all this is much less with a prepectoral breast reconstruction. So that is why that is preferred. So these are some of the things that you will be asked about. And as far as subpectoral are concerned, there is an increased risk of an animation deformity, meaning with the movement of the muscle, the implant will also show some changes. So this kind of animation deformities are common with subpectoral implants. So these are some differences which are mentioned in substance. I've just put it up here as a reference because questions can come from either the flaps which are going to be used, the zones which are going to have the best blood supply, the subpectoral versus prepectoral, and again delayed or immediate. Now, generally what is done today is something called as a delayed immediate combination type. In the sense, initially the skin flaps, the mastectomy, everything will be done, and what you can say as a silicone processes will be put inside. The silicone expander will be put inside, not the process. The silicone expander will be pushed inside, and the thing will be closed. Once you get the final report, if there is a need for radiation, in such cases it will be continued, and at the end of it, the expander will be removed, and then at that time, the actual, once the wound healing and everything happens, the skin changes, all of that settle. At that time, the actual implant will be put in, meaning it becomes a delayed criteria in case of a radiation which is needed. On the other hand, if the report comes back as negative, there is no need for, negative in the sense for high risk features, there is no need for radiation. In such cases, then the expander will be removed and the processes will be put in, which is kind of like a immediate reconstruction. So that is the favored mode of reconstruction, which is done currently as far as breast implants are concerned. Yeah, now there is a question on Phyllodes. We already had a discussion on Phyllodes with regard to whether a simple mastectomy needs to be done. Basically, there was one discussion I had with regard to the margins for Phyllodes. I already mentioned in Bailey it is given as 2 cm with removal of muscle, etc., etc. In Savillston, it is given, and in NCCN, it is given very clearly as 1 cm for intermediate and malignant Phyllodes. So you can go with that place. I wouldn't really mark 2 cm even if it comes as an option. I would choose, in case they have given borderline or malignant, I will choose 1 cm as the margin. In case it is given as benign Phyllodes, then it is excision. That's all is needed. You don't need to give any clear margins. You just need to excise it completely. Do not do an enucleation. Now, this is one question. I don't know the options which were given. True statement is proliferation of stromal tissue with variable ductal elements. That is correct. So what are the factors that we need to note? As I already said, there are a lot of areas from which the questions will come. So I've just put up all this in a composite way. So it is a biphasic proliferation in Phyllodes, where you have stromal proliferation and the epithelial proliferation, both of which will be happening. Now, why is it called Phyllodes? Phyllis means leaf. So it is a phylloid, meaning leaf-like appearance on cut section is what you will have. So you will have both the epithelial elements and the fibroblastic elements and the whorled pattern. All of this is going to give the appearance of a Phyllodes. This is a diagrammatic representation. This is the actual histopathological examination that you will be having. So essentially, this is the classical pattern of a benign Phyllodes. Now, in a malignant or a high-grade Phyllodes, what will happen is there will be ugly appearing cells, meaning it will have basically appearance of an invasive margin, sarcomatous appearance. These cells, compare this. This is all bland appearing cells. Okay, so this is going to be like a bland appearing cells. The stroma is more cellular here. In some ways, it can resemble a fibroadenoma, but in fibroadenoma, the clefts will not be so big. It will be just compressed kind of clefts. But here, even though it is more cellular, there will be very, very few mitosis, and the fibroblastic cells will be very bland in case of a benign phyllodes. On the other hand, in high grade phyllodes, you will have a hypercellular stroma, very, very high overgrowth of the stromal component will be there. The epithelial component will also be increased, but it is the stromal component that we need to pay attention to. So cellular atypia, increased number of mitosis, and stromal overgrowth, that is the main component that is directly related to survival as well. So this is going to be the main predictor of survival as far as the phyllodes is concerned. That is again come as a question, which is the most important component of your phyllodes for prognostication. That is going to be the stromal overgrowth and the stromal component, which is very, very important. Right. Now going on to PET-CT, when is it not indicated? Which condition is it not indicated? Which stage of breast cancer is it not indicated? Now remember, my friends, PET-CT is not a routine for many breast cancers. Contrary to what we might think, not every malignancy needs to undergo a PET-CT right at the outside. We don't do it for early stage breast cancer because the incidence of metastasis is going to be around 5% for liver, for lung, and for bone in early stage breast cancer in stage 1 and stage 2. So routinely, whether we need to do a PET scan or any, even for that matter, a CT scan or a bone scan, it is not indicated. That is the current dictum. Even NCCN says the same thing. So among these options, whenever we have something similar to this, we know that we can straight away rule out the locally advanced disease. So this is an M1 status. Clearly, this is an indication where we have to do a PET to find out whether any other sites of disease are going to be present. And then you have a T3N2 disease. Now again, N2, T3 is going to be locally advanced stage 3 breast cancer. Clearly, these two, C and D, are indications where you 100% have to go for a PET scan because they are all locally advanced breast cancer. You need to rule out metastasis to plan therapy. And in the fourth case, metastasis, you need to find out the other sites of metastasis. So this is all clear indications for a PET. Now, what about T2N1 and T3N0? Both of them come under stage 2. So do we need to do a PET scan in such cases? Does nodal staging predominate, or what does predominate? So in this, the answer, what I could discover, if you look at the NCCN guidelines, the current guidelines, they clearly say that PET is not indicated in stage 1, stage 2, and even up till operable stage 3, T3N1. Till T3N1, it is not recommended, is what is given in the guidelines. But that said, we have a choice here. So unless someone has given the wrong answers, we have a choice here. We have to choose one of them. Other option is you can leave it alone also, but then sometimes we need to take a little chance and mark it. So among these two options, the option that I would probably indicate is like, T3N0 is where I would not do a PET scan, whereas T2N1 is likely, somewhere where I will do it. Because in node positive disease, there is a higher chance of having systemic metastasis. What you can say is the Halstead's theory. It starts here, then goes to the lymph nodes, then spreads systemically. That still holds good. Size and nodes are the most important prognostic factor. We all know that in breast cancer. So that being the case, I would still say, because this is a node positive disease, which is mentioned, I would choose to do a PET here rather than here. So among the options which are given here, T3N0 is likely the option where we do not need to do a PET scan. All others is somewhere where we need to do a PET scan. And again, going by the NCCN, actually none of the options will apply. But I will say this, among the options which are given here, T2N1 we need to do, T3N0 we can possibly avoid because it is something where, it is a node negative disease. It is only the size. So I wouldn't really consider that as a criteria. Yeah, so now there is another lady's clinical picture which was given, like inflammatory breast cancer. We all know the clinical definition. See, you can see here that more than third, almost like, half of the breast is involved by inflammatory skin changes here. They have said that it's involved in 2/3 of the breast with ipsilateral fixed axillary nodes. What is going to be the next step in management? Now, remember, my friends, inflammatory breast carcinoma comes under T4D. You have to be very, very clear on that. And that is one case where we generally never ever operate. We do not give surgery as the first option for these patients. So let's see some of the options that I have listed. I actually got only one option in the MCQs, that is NACT followed by MRM. I just framed the rest of it myself. So NACT followed by BCS and axillary dissection, followed by BCS and targeted axillary dissection, MRM followed by CT and RT. So as I just now mentioned, MRM followed by CTRT is definitely not going to be in the cards. We don't need to plan for MRM first. We never plan for MRM first. It's contraindicated. So let's look at the other options. So we all know BCS is contraindicated. We know there are only very few indications where BCS is absolutely contraindicated, and one of them is inflammatory breast cancer, which is an absolute contraindication. So that rules out both BCS with axillary dissection and BCS with targeted axillary dissection. So the clear answer here will be establishing the diagnosis, then following it up with an MRM. And remember, my friends, in patients with inflammatory breast cancer, you may not have an underlying mass. So from the thickest area of the skin, whichever appears to be most malignant, you just do a biopsy, a wedge biopsy of the skin. There you will find the tumor cells. Demonstration of the tumor cells in the dermal lymphatics. That is the pathognomonic feature. If you find it, then it is classically inflammatory breast cancer. But even if you do not have it in the lymphatics, if it is present in the skin or somewhere else, still it is considered to be inflammatory breast cancer with the clinical picture. Here is one picture where both the clinical and this one will come together. And again, remember, my friends, the criteria which is taken by your AJCC TNM staging is at least 6 months. Less than 6 months should be the time duration of progression. If it is something which has progressed more than 6 months in the skin changes, then you consider it to be a neglected breast cancer. That kind of picture. That is another small point that I thought I'll make here. More than 6 months, if the appearance is there, it's unlikely to be inflammatory breast cancer. So the time duration from onset of symptoms till the patient comes to you should be less than 6 months, or when they notice and when they actually find out the progression and skin changes, that should be less than 6 months for you to call it as a inflammatory breast cancer. Now here is the contraindications again by the latest version of NCCN. Absolute contraindications where mastectomy is needed is inflammatory breast cancer or massive breast cancer with extensive skin and dermal lymphatics involvement. The other thing we know is, see, wherever we can't do BCS is like when diffusely all the quadrants, basically your multicentric disease, diffuse, suspicious, or malignant appearing microcalcifications are there. Inability to clear multiple positive margins. Now, one is the diffuse appearing microcalcification. Other thing is diffusely positive pathological or persistent positive pathological margin. So here, inability to obtain multiple positive margins, so clear the multiple positive margins, not like one positive margins, multiple times the margins are positive in one or more after doing one or more re-excision attempts. That is an indication for planning for a mastectomy. Then ATM mutations, this is something that I have already mentioned in the previous classes as well. ATM mutation is an absolute contraindication because of the fact that we cannot give radiation. That is the only reason. They are prone for developing radiation induced cancer. So after BCS, we cannot give radiation. So that is the reason why it is a contraindication. Now, the new thing which has been added in the NCCN 2025 is your multicentric disease with the following criteria. Now, neoadjuvant multicentric with neoadjuvant. If you're planning, then we don't know which one will shrink, which one will remain. So you have to basically remove the entire breast. Young age, less than 40 is a relative contraindication. It's an absolute contraindication in multicentric disease. Triple negative, again with multicentric disease. More than 2 lesions and more than 2 quadrants. Okay, so when that is there, any lesion, basically a T3 in one of the multicentric makes it ineligible. Questions of a BRCA mutation with a multicentric disease is a kind of mutation carrier, becomes ineligible. So in general, I will commonly group it as multicentric disease. Overall, multicentric is it's a contraindication. Why so many other things have come is like currently when you have a patient who is not triple negative, let's say who has got a luminal cancer, who's more than 40-50 years of age, all this is there. When you have a tumor in lower inner and upper outer quadrant, still you can consider doing breast conservation. That is the reason so many other indications have come in here. So you look at it as clearly where you cannot do a breast conservation. And again, whenever you have a bulky nodal disease, that is something with a multicentric disease where you're not supposed to do, and adjuvant RT cannot be given, then you cannot put the patient on this one. And clearly, one more thing, breast cancer and pregnancy is an often asked question. So look here, when a patient cannot receive radiation within 12 to 16 weeks, meaning somewhere in the range of, let's say around 3 to 4 months, if it is coming in the second trimester, meaning you can do a breast conservation, whereas in the first trimester, generally you have to do mastectomy. That is also there in the guideline. So patient with pregnancy and breast cancer is an absolute contraindication, provided you cannot give radiation within 12 to 16 weeks, meaning 3 to 4 months. If you cannot give, then there will be a delay in radiation. So then you cannot go in for sort of like a breast conservation treatment. Right. Now, related contraindication, again, other things like, traditionally what we say as genetic predisposition to breast cancer, Lee from any connective tissue disorders, history of prior radiation, all these are relative contraindications. They are not absolute contraindications. I'll make that very clear to you. Already mentioned all this in the classes. Only this multicentric component which you get here, that is the new thing in the current NCCN guidelines. And remember, friends, whenever we have inflammatory breast cancer, it's always going to be neoadjuvant followed by a modified radical mastectomy. Right. This was again a very clear question. There was no doubt at all. I think most of you would have marked it right. So this is something where we have presence of syndactyly, presence of absence of the pectoralis major, absence of the pectoralis minor, and the ipsilateral syndactyly or polydactyly. So this is a classical picture. I have actually put up this picture in the class as well, and this is right from Bailey. So this is your Poland syndrome, amasia, along with absence sternal head of the pectoralis major, and your this one, everything is a component of your Poland syndrome. And this, I actually said that it may come as an image based question, and it has come this time. So I mentioned that they may give it to you and they may ask you what is the syndrome, and probably it has come just like that. Someone is listening, maybe. Yeah. So that concludes the discussion on breast cancer questions that came up, breast and related questions that came up. Now going on to thyroid and its management. So thyroid based questions in NEET, where quite a lot of questions had come, almost 11 questions, 15 or 16 from breast, and we had some 11 or 12 questions from thyroid. So patient has a slowly growing thyroid mass diagnosed as papillary carcinoma thyroid. There is a sudden rapid increase in size of the swelling. What is the diagnosis here? I think this is a pretty straightforward answer that we have here. This is your anaplastic carcinoma. Slowly growing swelling, sudden rapid increase in size. This indicates a shift from the differentiated to the dedifferentiated or anaplastic type. Usually anaplastic can come de novo, or it can arise from a pre-existing polydifferentiated or other types of differentiated thyroid cancers as well. So can follicular, medullary or papillary present like that? No, they cannot. This is classically a picture which is anaplastic. It may be given as a dedifferentiated also, or poorly differentiated, maybe the way the question may be framed, but this is a classical question. I think most of you would have attended, and there is no doubt with regard to that. Now, this was a question. I'm not sure what were the options which were given here. So what were the mutations which were present in malignant thyroid, malignancies of the thyroid? That is what I think. I don't know what were the options which were listed. TRK MET RET was the option which was displayed, which is correct, of course. So the most common mutation that we find is the most common carcinoma, which is papillary thyroid carcinoma. We all know that the BRAF V600E valin for isoleucine, that is the mutation that we get here. That happens in about 40 to 50% of patients. This is the most common mutation that we get. Now, one other factor which is added is when you have a BRAF V600E along with a TERT promoter mutation, that is a poor prognostic sign in papillary thyroid carcinoma. Along with TERT promoter, BRAF plus TERT promoter mutation together, when you have it, that is going to be a poor prognostic indicator. That is going to be a poor prognostic indicator. The other factor, this is again directly from NCCN, and also it's given in Schwartz. Now, we all know that thyroid malignancies are related to radiation. The level of radiation which is needed, which is an aside point, it's not directly related to this question, but I thought it's important because a particular level was mentioned, is 0.1 gray. Even 0.1 gray of radiation can lead on to development of thyroid malignancies. This is very significant because none of the other organs are stimulated or get malignancies with such a low dose of radiation. But 0.1 gray, that is enough to lead on to development of thyroid malignancies. And the latency period is from 5 years till 30 years. Usually around 20-30 years is when you will develop radiation induced thyroid cancers, but it starts from the age of from 5 years from the time of exposure of radiation. And Bailey, I have mentioned this again in the classes that I have taken. So there are two types of what I can say as gene rearrangements that are associated in papillary cancers, especially in radiation induced papillary cancers. So the aggressive short latency PTC is associated with the RET PTC3 oncogene, or what you can say as the translocation. The less aggressive one is associated with the red PTC1. PTC1 is less aggressive, PTC3 is going to be highly aggressive. This is something which I have already discussed in the class, right? So the clinical picture of Hashimoto's thyroiditis is associated with which carcinoma? This is again a straightforward, very probably some of the easy questions that were given. The answer is, of course, thyroid lymphoma. But remember here, my friends, that papillary thyroid carcinoma is also associated with Hashimoto's thyroiditis. So it is not just your lymphoma, which is the classical. I mean, most common is lymphoma. Again, I will say the order here because many of you had this doubt even in the class. So the most common one is going to be lymphoma. The second most common is going to be your PTC. Both of these are associated with Hashimoto's thyrotoxicosis or Hashimoto's thyroiditis. So in long term, Hashimoto's thyroiditis can lead on to lymphomas and also to papillary thyroid carcinoma. Going on to the next question on thyroiditis, we have granulomatous thyroiditis. Clinical picture. Maybe the picture was given like pain, like fever, like enlargement of the thyroid. This might have been the presentation. So this is classically what you see in granulomatous thyroiditis. So how will you manage the pain? Do you manage only the the fever and the pain, or do you give oral steroids? How do you manage it? So I thought I'll just put up some factors with regard to your granulomatous thyroiditis. Granulomatous or subacute or decurvent thyroiditis is something where you will have a classical presentation of pain, low-grade fever, and swelling in the thyroid region, along with dysphagia and fatigue. And usually there will be a viral infection which will predate it. More often than not, you will get some patients who have an upper respiratory infection followed by a short while later, like 1 or 2 months later, they will develop this kind of picture. So on FNAC, you will find the classical multinucleate giant cells and granulomas on FNAC that will clinch the diagnosis. What are the things which are classical? Raised ESR. This has been a question that has come a couple of times, and low radioactive iodine uptake. That is a question again that has come, which is the wrong statement with regard to this. So low radioactive iodine uptake is classical. Now, previously people used to do, because it can present with some degree of thyrotoxicosis or hypothyroidism. So people used to do radioactive iodine scans for that. So the classical feature will be a low radioactive iodine uptake in your what you can say as your thyroiditis, which is associated with granulomatous thyroiditis or decurvent thyroiditis, and it has got a raised ESR, both of which are classical. Now the management of the pain associated with it. Now there are two different answers with regard to Bailey and Sabiston, but Sabiston gives a very clear answer that in decurvent thyroiditis, initially the pain is treated by symptomatic methods, by painkillers. Basically, you give them NSAIDs and you can treat the patient's pain and symptoms, both of which will resolve by giving this. In severe cases, we will need a course of steroids, start with 10 to 20 milligrams of prednisolone. So initially, do we need steroids in the management? The answer is no. Only in non-relenting cases, in severe cases, we'll need it. In Bailey, it is given that you can give symptomatic treatment. They have not given the words as non-steroidal NSAIDs basically, but they have said symptomatic, and later on we can add steroids if it is needed, is how they have given. So I would stick to the management here as symptomatic treatment of pain initially by giving NSAIDs, and if it is not resolving, then to go for oral steroids as the treatment. That is the way probably I would mark this question. Now, there was a question of a clinical picture of a thyroglossal cyst. Most of you would know how a thyroglossal cyst is going to look like. I just thought I'll put up a picture on embryology and the various locations of the ectopic thyroid glands. We all know it starts from the foramen cecum of the tongue. So you can have the ectopic locations as lingual, sublingual, subhyoid or perihyoid locations. You can have infrahyoid is again one thing. Pre-thyroid, it can be there. Pre-laryngeal, it can be there, which is going to be the common locations. And then it will come in front of the trachea. And sometimes it can go on to the mediastinum as well. That can also happen. So along any of these parts, you can have the thyroids, which will kind of go on. This entire tract is known as the thyrothymic tract. So thyroid and the thymus, both of them will get pulled along in the same tract. And you can have ectopic thyrothymic rest. Now, thyroid is supposed to stop here, but you can have ectopic thyrothymic rest, which can happen in the region of the thymic tract. Now, of course, we all know that the thyroglossal cyst is usually along the, just infrahyoid is the most common location, and towards the left is more common. Infrahyoid and towards the left is more common. And we all know the management is going to be the Siston's procedure, where the entire tract has to be removed. Importantly, you have to confirm the presence of normal thyroid tissue, because sometimes this may be the only functional thyroid tissue. So in cases, how do you confirm? Very simple. You do an ultrasound. That will be good enough to show a neck presence of the normal thyroid tissue in the neck. And once that is confirmed, then you can just go ahead and you can resect the thyroglossal cyst, the entire tract, including the central portion of the hyoid bone and almost till the foramen cecum. And previously, people said that you have to go till the foramen cecum and remove it completely. Now, this tongue part of the operation is usually not done. You go till the mylohyoid diaphragm here. You just remove the central part of the hyoid bone, and then you remove this area. Tongue part, you don't take it. You just leave it unless the tract is actually a clear tract is going up. You don't usually go into the tongue and you don't take it. So you generally take out the central part, and then you take out the the tract, and then you come down and take out the entire tract. Now the distal part of the thyroglossal tract, which is going to remain, that is my thyroglossal duct, which is going to remain, that will usually be seen as the pyramidal lobe. And this is of course the tubercle of Zucker candle, which is going to be something that is going to serve as a marker to the nerve. So these are some things in association with the thyroid that we need to know about. Right. Now, this is an interesting question. So, a surgeon was doing thyroid surgery. He was unable to achieve adequate exposure and he asked for a retractor. What retractor would you hand over to him? Some of the options which are given to me are the Jones retractor, the weight liner retractor, and the Omnitract Peri. So, these were the options that were given here. I put up all the three pictures here. Now, remember, my friends, classical answer, and probably I would stick to it, is actually the Jones retractor. Thyroid retractor is the Jones retractor. This one is the Jones retractor. Classically, you kind of have a clip which you apply on the upper and the lower poles, I mean, of the incision, the upper flap and the lower flap, and then you rotate this knob here. This particular knob you rotate here. This is the clips which are going to be there, and this is the knob. So you just rotate it. People who have not used it, I've just used it once, I believe once or twice I've used it. Practically, I prefer to take stitches or clips. So this one can be applied, and the problem with this retractor that I face is it will be kind of like a kind of like a triangle. It will open it, so the lateral edges may not actually get properly retracted. You will still need a bit of retraction in those areas, but I know people are fond of using the Jones retractor. But currently you also have, I mean, this is again an old instrument. It's not a new thing. I'm sure all of you would have used it in small surgery. So this is known as the weight liner retractor. So the white liner retractor, that is something which was propounded by a surgeon called Whiteliner. He was an Austrian / German surgeon who actually designed it in the periphery. When he was operating, he didn't have anything to help him. He didn't have anybody to help him. So he just designed this retractor. It's not known by that name for many of us. All of us have used it, but we don't know the name. It's interesting. It's called as the white liner retractor. And then currently you have the mini tract or the mini omnitract, whatever we call it. So that kind of thing is also available for specifically for the head and neck. There are people who are using this as well. So I do not really know, because in this particular scenario, was doing thyroid surgery, unable to adequate exposure. So they have not mentioned anything with regard to the size of the gland. So classically, I will stick to the thyroid retractor, which is going to be the Jones retractor. But these are all options which are available. It's not necessarily only the thyroid retractor. The weight liner, of course, is unlikely to be used, but Jones can be used. And you do have the mini tract, as they call it, or the mini omnitract, as they call it, that is available now, which can be used in a lot of head and neck surgeries currently for people who do not have so much in terms of help with them. So that is also available. But the answer here, I think I will stick to Jones retractor. Right. Now the question is, large smooth thyroid mass arising from both the lobes in front of the neck. There are no symptoms other than the mass, and there is no evidence of compression. FNAC does not show any sinister features, but patient is worried about the ugly appearance. What will you do for such a patient? So you look at the options which are there. You reassure, you do a lobectomy, you do a total thyroidectomy. What do you do? Now, this is a pretty impressive question in the sense that, this is practically what we need to face day in and day out. It's not just about knowing what you need to do in terms of risk factors and everything. It is about facing the patient. It is about telling them, or sometimes doing what they need as well. And if you look at your Bailey, there will be one word which will be mentioned as cosmesis. So if the patient is worried about an ugly appearance, that means there is a cosmetic indication for doing the thyroid surgery. And since this is a smooth thyroid mass which is arising from both the lobes in front of the neck, so both the lobes means you have to do a total thyroidectomy for this particular patient. So I would not currently recommend reassurance as the option, because it's mentioned clearly as a large smooth thyroid mass. So there are likely to be, again, can you just leave this patient by reassurance? Because over a period of time, it can cause compressive symptoms, it can turn malignant, it can cause a scabbard trachea, it can cause tracheomalacia. All these things can happen in the long term. So all the more there is an indication. It is all meant to confuse you, but it is very, very clear. So there are some indications clearly saying why you should actually do a thyroid surgery for this. But importantly, this is the fact: the patient is worried about ugly appearance. So cosmesis is one of the reasons which is mentioned as a indication for surgery in Bailey. So we will go with that. The answer is a total thyroidectomy that we have to do for this particular patient. And then, of course, we have the question on MTC is associated with which syndrome. I think it's a very clear, straightforward question. It is MEN2 syndrome. All of us know it. Remember, do not mark it as MEN1. Only MEN2 is defined by the presence of MTC. Almost 100% of patients with MEN2, 99 to 100%, I believe is the number which is quoted. All of them will have the MTC which is associated with it. Okay, so the MEN1, MEN2A, and MEN2B, or MEN1, 2, and 3. So MEN2 is the one which is associated with your medullary thyroid carcinoma. Now, there are other syndromes which are associated that have come, especially Cowden syndrome. Okay, Cowden syndrome is classically associated with your FTC. The P10 syndrome or the Cowden syndrome is associated with follicular thyroid carcinoma. All the others are usually associated with PTC. MTC, of course, we know the syndromes, but Cowden syndrome is classically associated with your follicular thyroid carcinoma. And incidentally, I found a very nice, tabular column in Schwartz, which lists all the oncogenes and the tumor suppressor genes, everything. This is in relation to the previous question as well. What are the genes which are associated with PTC? So if you look at it, the red proto-oncogene classically is associated with MTC, but it is also associated with your PTC, because I just now was mentioning the red PTC3 and red PTC1 rearrangements which are associated with your papillary thyroid carcinoma. So all of them are associated with the red. Now, red is a tyrosine kinase activating receptor. So the same way you have the MET. TRK is a tyrosine kinase receptor. All three are the tyrosine kinase based receptors. So RET, MET, and TRK, all of these are associated with PTC. RET, of course, is classically associated with MTC as well. Now, these three, I don't know the question how it was framed. Maybe the question came as papillary thyroid carcinoma and it is directly taken from this. I don't know how the question was framed. The one that I was mentioning before. We had a discussion on that question, a couple of cases, a couple of things before. Yeah, this is the one. Which of the following is seen in malignant papillary carcinoma thyroid? That might have been the question. So other than your BRAF V600E, we have the red proto-oncogene with PTC rearrangements. We can have the MET and the TRK as well, which is happening. So very clearly, this is a very beautiful chart which is given in Schwartz, and I will be sharing the PPT as well. You can get it from that, and it's mentioned in Schwartz as well. So RET, MET, and TRK, all three are associated with PTC. Now, TSH receptor, we know TSH stimulating receptors are associated with your Graves' disease or hyperfunctioning adenomas. We know that, and again, same thing is in GS alpha. Now, RAS is very, very important. RAS is associated with your follicular adenoma and follicular carcinoma commonly, sometimes with PTC as well. The problem with RAS is, of course, the numbers. We know that whenever we have an FNAC of a follicular adenoma which comes in, we subject it for molecular studies, and RAS is one of the markers which is mentioned, which can be studied. The problem is 80% of follicular carcinoma has RAS, but 40% of follicular adenoma will also have RAS rearrangement. So that is the problem. So it is almost like half of the benign variant also has it. So that is the difficulty. And then, of course, we have the rearrangement, PAX8 and PPAR gamma, peroxisome alternating receptor gamma. That receptor is also involved in follicular adenoma and carcinoma. That is again one of the markers which is used in the gene expression classifier, the gene sequence classifier, the Syro sequence version 1, 2, 3. All this, they use various combinations of these genes. And of course, we know the BRAF, which is classically found in PTC. We just now discussed this. Beta-catenin, it is found in poorly differentiated and in anaplastic cancers. Remember, this is a component of Gardner syndrome as well, which is a variant of FAP, and it is associated with your PTC. Third promoter, as I already said, is associated with PTC, FTC, and anaplastic. Third promoter usually indicates a poorer prognosis. Whenever it is found, it indicates a poorer prognosis. And then the classical P53 and P16 or retinoblastoma, all this are associated with many of the malignancies. And P10, Cowden syndrome, classically associated with your follicular carcinoma and follicular adenoma. So P10 is one thing which is slightly different, Zara Hatke, as you can say. So the ones which are associated with follicular are your P10, Cowden syndrome. Then you have your PAX8, PPAR gamma, and your RAS. All these are more commonly associated with follicular adenoma and your follicular carcinoma rather than with your PTC. And of course, you can have microRNA mutations which can happen. So papillary and follicular carcinomas, both of this is a very nice tabular column which shows oncogenes and tumor suppressor genes. I believe a few questions have been taken based on Schwartz in this current, NEET. That is usually comes from Sebastian and Bailey only, but this time I think Schwartz has been one of the areas from which they have taken the questions, because some of these reflect the pattern. Right. Now, there was a question on which is a contraindication for, I believe the answer should be, question should be total thyroidectomy. I'm just taking the questions and putting it as it was given to me. So here the answer is probably what I will mark as negative molecular profile on thyrosequence 3. Why? Because thyrosequence version 3 is one of the molecular tests which will be used whenever you have a Bethesda 4 on Bethesda 3 on FNAC. So you can do the molecular testing and you can just do a hemithyroidectomy alone. There is no need to do a thyroidectomy because it has got a very high negative predictive value. The negative predictive value for thyrosequence version 3 is almost 93%. So almost sure you can confirm that it is unlikely to be malignancy. So when you have a negative thyrosequence version 3, you can actually avoid doing a thyroidectomy. Now, I don't know the exact question. I think it's probably because the one other option which was mentioned was history of radiation. I thought it must be in relation to total thyroidectomy. That is why I mentioned the options here. Now, this is something again we have discussed in our class. So what are currently the indications for doing a total thyroidectomy as compared to a lobectomy? Lobectomy meaning a hemithyroidectomy alone. Now, most cases today we consider doing only a hemithyroidectomy. Where must we do always? Where should we do a total thyroidectomy? For that, the answer is T3 tumors, T3A. So that is what is this one? Tumor more than 4 centimeters. Then you have gross extrathyroidal extension. It is going to come in T3B. Then M1, obviously, whenever you have metastatic disease, you need to remove the entire thyroid so that you can treat the patient by giving radioiodine therapy. Actually, all these three are indications for giving radioiodine therapy, and that is the reason why we need to do a total thyroidectomy. Now, other than that, imagine a process which will diffusely involve the gland. One is going to be the familial non-medullary thyroid cancer. So familial cancer, which is non-medullary, because medullary is the most common familial thyroid cancer. So if you take away the familial medullary types, then you have the familial non-medullary clustering of cases. Whenever that is there, again, that is going to involve all the cells. It's not just one lobe which is affected. So there you have to do it. Radiation affecting is again going to be for the entire thyroid. It's not going to be to one side. And multifocal and bilateral differentiated thyroid cancers, obviously whenever it is bilateral we have to do. So these are all the indications currently for differentiated thyroid cancer where you have to do only a total thyroidectomy. Right now, again, an interesting question. MTC is always a little confusing. How to manage MTC? There are a lot of controversies in management, but some things remain. So I'm not sure what was the question which was asked. The one option only was listed: prophylactic lateral neck dissection done if the primary is more than 1.5 centimeter. I'm not sure what were the options which were listed. So I just thought I'll go through the guidelines for MTC. Now, MTC can be familial, can be sporadic. Now, red proto-oncogene mutations are almost, I mean, it is guaranteed whenever you have a MEN2 syndrome, but it can also happen in about 50% of sporadic men, sporadic medullary thyroid carcinoma. So whenever you have a sporadic, still 50% can have a somatic red proto-oncogene mutation. So that can also still happen. Then what else do you have? What is the management for MEN syndrome? So MEN syndrome, we know the ATA high risk category, highest risk category, and the moderate risk category. Highest risk is going to be the one where you will completely do a thyroidectomy before 1 year of age. Less than 1 year of age, you will do a total thyroidectomy. In this scenario, because you're doing a prophylactic thyroidectomy, there is no need to sort of remove the neck nodes. And again, when you have the this is the highest risk category, then you have the high risk category. So M9180 mutation, that is the one which is exon 16 mutation. Whenever you have, that is the highest risk where you have to do a total thyroidectomy before 1 year of age. When you have the high risk, which is the codon 634, and also your mutation in the A883F mutation. So these two, whenever it is present, then it is considered to be high risk, meaning exon 15 and also exon 9 mutations which will be present. So in these cases, you will have to consider going in for your other types. So all others will come as the moderate risk where you will do the total thyroidectomy after 5 years or depending on the calcitonin levels. Previously, it used to be considered as 20 years of age. Nowadays, we give it based on the calcitonin levels. If the levels are rising, then we do. Otherwise, we can observe such patients. So highest risk category, M9180, less than 1 year of age. All the others in the high risk category, codon 634 and also your exon 15 or A883F, that one you'll have to do it at the age of less than 5 years. All others, one you can choose a wait and watch policy or you can do it at around 20 years of age. That is the guideline. Now, as far as the neck is concerned, how do you manage? Now, in medullary thyroid carcinoma, there is no role for anything other than a total thyroidectomy. Always a total thyroidectomy is done. What about the neck? Any clinically detected MTC, meaning patients come to you with a neck swelling or a neck node or anything like that, wherever it is a clinically detected medullary thyroid carcinoma, always you have to do a total thyroidectomy with the bilateral central neck dissection, the level 6 on right and left. Remember, there is a right and left in level 6. So right and left level 6 always have to be dissected in patients who have a clinical medullary thyroid carcinoma. Why? Because the incidence of nodal metastasis is almost 70 to 80%. So all cases you have to do a central neck dissection. That is the minimum treatment. Only in prophylactic surgery you can avoid the central neck dissection. Right. Now you have the ATA guidelines, which where will you do an ipsilateral neck dissection? So that was the question. Prophylactic ipsilateral neck dissection. Obviously, when it is node positive, you'll do. That is a clear question. But the ATA 2015 guidelines also mention a calcitonin level which is more than 20. So if your calcitonin, serum calcitonin level at baseline, which is measured, is more than 20, then you have to do a ipsilateral neck dissection. And if you have positive central neck nodes which are present at the time of surgery, then suppose you have a right side nodule, neck nodes appear positive in the central neck, then you have to do the right lateral neck dissection. Then again, it's an indication. Then in Schwartz, there is also another thing which is mentioned, primary tumor more than or equal to 1.5 centimeter. This is given in Schwartz. Both the positive central neck and the primary tumor are actually mentioned in Schwartz. So I'm not sure what is the answer, but ATA guidelines do not mention the size of the primary tumor as a criteria. They only mention the calcitonin levels and the central neck nodes being positive. Then you have the contralateral neck dissection when you should do when the level of calcitonin goes up more than 200 nanogram per ml. Some books mention as 150. ATA also mentions when it is more than 150, you have to go for a, kind of like a contralateral neck dissection. So there is a slight discrepancy in the levels, but in general, the lateral neck dissection, there is a very low threshold. Whenever you have central neck nodes positive, whenever you have a level more than 20 and the tumor size is probably more than 1.5, you have to do a ipsilateral neck dissection. Contralateral is done when the level is more than 150 or 200. So that is the management of your medullary thyroid carcinoma, which is the false statement. I'm not sure. I don't have the other options here. So, but these are the relevant things which I thought you should all know. Right. Now, thyroid nodule measuring 1.9 into 1.7 centimeter, which is the false statement. Now, clearly the answer here is spongiform nodule or cystic nodule. You do not do a thyroidectomy. There, the criteria for even doing an FNAC or a biopsy is more than 2 centimeters. This again is something which I have discussed extensively when I was dealing with the thyroid chapters here. So any solid hypoechoic nodule with high risk features, then, or whenever you have that, whenever there is high risk features like microcalcification, when there is a irregular margin, when the taller than wider calcification is there, rim calcifications are there, microinvasive or microlobulations are there, extrathyroidal extension is there, all these are high risk features. So their size cutoff is 1 centimeter. And again, whenever you have an intermediate suspicion lesion, also again the same thing will happen. So basically any solid hypoechoic lesion, so you have to go for an FNAC or a biopsy more than 1 centimeter. On the other hand, when it is very low suspicion like a spongiform or a cystic nodule, there you will do it only when it is more than or equal to 2 centimeter. Before that you will not do it. And cystic lesions, you can avoid doing a biopsy. Cystic lesion, because the risk is very, very low, you can avoid doing a biopsy. Now you look at this particular question, the choice is 1.9 into 1.7 centimeter, and that is why either cystic or spongiform, you will not do thyroid surgery. So that is a very clear option. Though it is based on this, it is something which we have discussed quite a lot of times. Okay, right. Now, this was again an image. Now we are going on to thoracic. So a lot of questions from thyroid, and again, most of them are from areas that we have discussed quite extensively, except for one question. I believe all the questions we have discussed previously during our classes. So it's going to be very clear. And this is, of course, the Bailey image was apparently given. This is how a bronchoscope will look like. This is the flexible bronchoscope, and this is, of course, the rigid bronchoscope. Rigid bronchoscopy requires a general anesthesia, whereas a flexible bronchoscopy is something which will be easily done under local anesthesia only. There is no need for even sedation. You will just give local jelly application here, and maybe a throat spray you will do. And this is the view of the both the bronchi. You can actually see only one bronchus. You can see the left main bronchus here. The right main is hidden here by this fold, and this is your carina, and you can see the left endobronchial. I'm not sure whether it's endobronchial, but there is a tumor here inside the bronchus here. So this is the tumor in the bronchial lumen. So you can do an assessment, you can do a biopsy, you can do bronchoalveolar lavage from here. And in patients where when you have the facility for EBUS, meaning endobronchial ultrasound, you can do a biopsy from a lot of the areas. If you look at the stations, station 2, 3, 4, station 7, 7 will be here, subcarinal, it will be there. So all of these stations can be usually accessed by doing a endobronchial ultrasound, and you can do an FNAC in many of these cases. So that is again a question that has come up sometimes. Which cases will you do a mediastinoscopy? Which cases will you do this? That is again something which has been discussed. I have, I believe, I'm not sure whether I shared it with you guys because I was not taking this chapter for you, but that is there in Bailey. You can look at it. It's a very clearly defined column which mentions what stations you have to do, what procedure to identify whether you do a VATS or whether you do mediastinoscopy or whether you do a endobronchial ultrasound for biopsy. That is very clearly mentioned as a tabular column in Bailey. Now, this is again a very classical picture. No, it's a very, very classical picture which is given. I'm not sure whether the same picture came, but I believe something similar had come. Enlarged, painful toes and fingers, which are seen along with classical periosteal thickening. This radio graph was given with an elevated periosteum and all that. So this is the picture of your hypertrophic pulmonary osteoarthropathy. In malignancies, this will usually happen in non-small cell carcinoma, especially with adenocarcinoma. This is common, HPOE, hypertrophic pulmonary osteopathy. It can happen with other things like empyema and other things as well, but commonly happens with your malignancies. Most common thing will be your adenocarcinoma of the lung in today's world. That is the most common place where you will get your HPOE, or a lot of image-based questions will come. They are all pretty simple to answer. This, I believe, again was a question directly from Bailey based on the image. So you have you can see here that the image is there of a perihilar or a hilar tumor on the left side. And after this image was given. So what is this? Is this hydropneumothorax or is it a normal sequelae? So this is your post-pneumonectomy X-ray. This is the normal sequelae. In your post-pneumonectomy scenario, you generally do not put in a drain. You do not put in an ICD. Unlike any other lung resection on that side, you will put in a drain. Here, you want the fluid to accumulate and fill up the space to prevent the dragging of the right lung onto the left side. The collapse of the side should not drag the contralateral lung. So you will not put a drain. You will just leave it like that. And this kind of hydropneumothorax is the picture you will see on the first couple of days. It will just gradually fill up and totally occlude it. And that is how it will look like. And generally after that, it will resolve and it will get fibrosed on that side. So that is the kind of picture which you will get in your pneumonectomy. So this is a normal sequelae of your post pneumonectomy with your air fluid level hydropneumonia. It's not hydropneumonia. It is kind of like hydropneumothorax, but this is the normal sequelae post pneumonectomy, right? Now, again, there was another question which came with regard to your hyponatremia. So hyponatremia with a level of 128 milliequivalent is seen in which lung carcinoma? This is a very classical question. SIAD is the presentation. Syndrome of inappropriate ADH excretion, euvolemic hypoosmolar hyponatremia, classical sign, one of the most common paraneoplastic syndromes that you will get with small cell lung cancer. In fact, small cell lung cancer is the one that will be associated with a lot of paraneoplastic syndromes, Lambert-Eaton syndrome, this one, a lot of your CNS syndromes are associated, myopathic syndromes are associated. Many of them are associated with your, small cell lung cancers, and hyponatremia is one of the commonest syndromes that can come here. It is due to ectopic ADH secretion here. And, hypercalcemia of malignancy can happen. That will usually happen with your non-small cell lung cancers. With squamous cell, it is very common. So you will get that kind of presentation. So hypercalcemia of malignancy, hyponatremia, all these are common. Hyponatremia classically happens with your small cell lung cancer due to CR, syndrome of inappropriate ADH secretion, because of ectopic ADH presentation. It happens in almost, 20 to 30% or 40% of your small cell lung cancers. Now, I think this was what was given. There was only one option which was given. Small cell lung cancer cannot be cured by. That was all was given. I wasn't getting the whole option. So I just made up a few options and just thought I'll put up a few statements on management of lung cancers. So can it be cured by surgery alone? The answer is no. Unlike other things, almost always you need chemotherapy as far as small cell lung cancer is concerned. Every case requires EP chemotherapy. So all the small cell tumors will require etoposide cisplatin combination. EP stands for etoposide, P for platinum. So EP chemotherapy is the one which will be given in all your small blue round cell tumors. Any of them, the solid tumors, you will be using your EP-based chemotherapy. Cisplatin and etoposide will be used. So the same thing applies in your small cell lung cancer as well. And additionally, you need to do all the other things. This is just a statement, so all the others are false. So early stages need chemotherapy in NSCLC? No. If you have a tumor which is less than 1.5 centimeters and all are favorable, then you can avoid chemotherapy in your T1 lung cancers. Paraneoplastic syndromes I just now mentioned are more common in your small cell lung cancer. It's not common in your non-small cell. It can happen in non-small cell, but it is more common with your small cell lung cancers. And craniospinal imaging is mandatory in small cell lung cancers because there is a tendency to develop cranial metastasis, especially leptomeningeal spread. All this is very common. So an MRI is actually needed, not even a PET scan, because PET scan cannot detect metastasis in the brain. So that is one thing which you have to remember. In small cell lung cancer, you always have to do craniospinal imaging. In fact, some people prefer to do a lumbar puncture to look for the cells as well in your spinal, basically in your CSF. So this kind of craniospinal imaging is needed with an MRI in small cell lung cancer. So that brings us to the end of the discussion today, and we have covered most of the important topics. Bit here and there from GIT. I've snatched a bit and all that. I've made a PowerPoint today. I'll stop with this session because the next sessions and everything is there, and I'll just put up in the group after discussing with the Dr. Tutorials team when the next session is going to be. And all the best, my friends, for INASs as well, because a lot of these questions, go through them again, they will come in INASs also. It's not necessarily for NEET SS alone, it's going to come up in INASs also. Many of these are overlaps. In fact, I'll try and do a session where you can just see the overlap. Frankly speaking, it is all coming again and again. It's the same areas. It's not necessarily the same question, but the same areas will keep coming in again. And I request you earnestly to go through all the questions. That is very, very important for you, because the questions are, many of them are, in the same areas. You read the same things, you will definitely crack the exam. So all the best, my friends, and I will put up the date for the next session and also for the INASS discussion. Thank you.